It's my pleasure to bring Sandy Saggar, CEO of Connexall, back onto stage. I also want to take a minute to introduce Jan Capps, who is the Director of Clinical Outcomes and Services for Connexall. She's a senior healthcare technology executive specializing in clinical informatics, data analytics, and healthcare IT. Please join me in welcoming Sandy and Jan.
Maybe we'll do it. Thank you. We're back. Lunch was good? No dozing off. The first session after lunch. Okay, so Jen and I are going to talk about...
Whatever you want.
Yeah, okay. Clinical Elevate, but first, maybe just a little additional background. Maybe I'll hand it over to you, Jen. You want to give a little background about yourself?
Well, Jane already made me sound fantastic, so I'm not sure what else I can add to that. But seriously, I've been in healthcare in some capacity for close to 30 years. The last 26 of those have been as a registered nurse working in various different practice settings. Half of that's been spent on more direct care clinical roles and the other half on technology. And, I'm often asked, how do you end up being a nurse and end up in the tech industry? And I always go back to, we can debate nature versus nurture all day long, but my mother is a nurse and my father is a computer programmer. So it just seemed to fit. And so when this opportunity with Connexall came along, it was just a perfect role for me. And I've been with the company for a year, 2 days shy of a year anniversary.
Yeah. So we brought Jan to WorldConnex to celebrate, not just the 25th anniversary, but Jan's 1 year anniversary.
Yeah.
We're really focused on, with Jan's leadership, growing the clinical team and the presence to help with the product roadmap, to help with working with all of our customers. We're really excited about the work we're doing, which we'll get to shortly. And Jane already introduced myself, so I'm going to skip that part. So, anybody feel like this on some days? Show of hands. Any days? Every day? Yeah, we got an every day. There is so much information out there. We are all experiencing information overload. And, this has an impact on our health. It has an impact on our productivity. It impacts our mood, right? And so the constant flow of information is something we all feel in our personal lives and in our professional lives. And reasons for this, right? There's more information than we can consume, right? We all know that, right? With the internet and the digital age, there's a bombardment of unsolicited information we don't need, we don't even know why we're getting. Maybe it's spam, maybe it's something else. The speed of information, right? Now you've downloaded all these apps, you have all these news outlets, you have and it's coming from Teams, it's coming from Zoom, it's coming from email, right? So the acceleration and avenues of information as well. And then we're dealing with sort of like this decreased value of information, right? Like where's there misinformation? What is the source of truth? Where do I need to spend my time and energy when it comes to information? So, really a focus on we've talked a lot over the years about the information age, but we're also grappling with the attention age. Like, what am I going to pay attention to? Where do I pay attention? And what's most important? And, we can talk about this in, obviously, our personal lens, but also from a healthcare lens as well. So, I'm going to take you back in a time machine to 2007. Anyone remember what launched that year? Yes. So, no one's ever done this slide before, right? I'm the first. So we had the real smartphone, right? What I call the real smart. And with that, I don't think we realized that it's really combining a whole bunch of technologies into one, right? So, it wasn't just the phone and email. It wasn't. And now you got this proliferation of applications as well. And if we felt information overload before, how could we not feel it now? So imagine in the palm of our hand, as we download a new app, it's almost like a new technology, right? It has its own alarms, its own notification, its own life, and it wants your attention all the time. So who has to deal with this? Show of hands. Anybody? Oh, look, and the paddles are being used too. Great.
Oh, yeah.
So this is our normal life. This is what's happening constantly on our phones. How many of you have taken the time on your phones to adjust for this, to reduce? We got a few, maybe a third, somewhere in that range. And so there is some effort to adjust for this because, again, the more you get of this, the more you're going to miss. Now, who misses things? Who misses calendar alerts, emails, important items? Show of hands. Who's missed items because they got too many notifications and alarms? We're all human. This is going to happen. And so every time we pick up our phones, we're overwhelmed. It's funny for the third of you that put up your hand. On the flight over here, I took the 3 minutes, 180 seconds it took to bundle my non-critical notifications to come to me once a day. Like, out of all the apps I had. And I'm not joking. I was like, oh, I didn't know this feature existed. I could bundle these, and I just never spent the time. But things are set up for you to do this type of thing and to organize your life, personal life. And, you know, we've all had personal experiences where we feel overwhelmed. So, Jan, I think you probably have some personal experiences too.
I do, but I didn't accomplish it in 180 seconds. I actually bought a new car this past year for the first time in like 12, 13 years. So that tells you I'm either resistant to change or very frugal or somewhere in between. But it's not just your phone. I mean, you see the image on the right side. That's a Tesla, okay? We expect it to look really sharp and have all the automated stuff. The car on the left side's what I bought, and it's still computerized. You know, so everything is just computerized. Notifications. I had to figure out how to disable all of this because it took me like 10 minutes before I could leave the driveway to figure out what I wanted to configure and how. You know, it was just too much, and because it was too much, it became very, very frustrating for me. But again, it's how do you customize it to where you get the right amount of information? You know, one of the first things I had to figure out how to disarm was this annoying little pop-up that was like the heads-up display to beep and give me a visual cue that the car in front of me at the red light had moved. I mean, I obviously knew that. I'm driving, I'm looking in front of me. I mean, I didn't need that. That was overkill. And so, you know, when you have all this information coming at you, I mean, you really do have to pause and reflect and try to find that balance. What's value add notification versus what's just annoying as all get out. And I think that this bleeds over into really every aspect of, you know, of what we encounter now, and probably even into healthcare.
Absolutely. So, another time machine. It's my theme for the day. Now we're going to go to 2015. And I was, at the time, CIO at a health system. And we were opening up new hospitals in 2015, and also we had one planned for 2017. We were challenged with the amount of technology that was being implemented because smart hospital design needs to be planned out of the get-go, and all the change that was going to come for the clinicians. Luckily, we were able to implement with all, again, the new medical devices and technologies, 85% of the new at legacy sites. So it was great and fantastic because it was an opportunity to help the clinicians in their day-to-day work and get that change structured ahead of time. What we were not able to completely get ahead of was the amount of notifications and alarms that the clinicians were going to get with all the new technology that we were not able to implement at the legacy sites. And so about 3 weeks after we opened up in 2015, this sort of bubbled up to all the people that, perhaps, were busy doing other things, because a lot of hard work opening up a new hospital, as many of you have. And so we actually had these, what I call pressure cooker meetings, because it was like, what do we do? It was 3 weeks away. Long story short, we ended up opening up with everything that we designed for. And, I waited. I waited to say, we're going to have an optimization phase. We're going to be able to go back and we're going to look at, alarm management. We're going to look at alarm fatigue. But then my next redevelopment project was in 2017. And so, like everything else, lots of priorities. Years went by, and, I tried to continually raise, this awareness that we need to go back to the front lines and help the clinicians, because at least when I walked out to the units and I heard from frontline clinicians, this was something we needed to tackle. One of the biggest challenges at that time was internally or externally, there wasn't necessarily a program for this. There wasn't something I could just say, here, share with clinical leadership, right? It was sort of a concept. We needed to look at it. Everyone was dealing with it. But we also had a lot of other parties. And at the time, it would have been so helpful to say, here's a program that can help deal with alarm fatigue. And so, Jan, you're a clinician. Mm-hmm. You've seen it from many sides. I'll hand it back over to you.
Yeah. So, as I said, I've spent half of my career more traditional clinical bedside roles, the other half being an IT leader. And so I look at it from really two different perspectives. So given our audience here, again, rhetorical question, but who in here has been involved with a healthcare technology project implementation, right? Everybody. Okay. Now put your hand back up if it went exactly the way you thought it would. Yeah. I mean, people are ducking under the tables because they don't want that to be there. And that's true. That's true. There's always some type of a hiccup. I mean, we heard Monique speak to it. We heard Alicia speak to it. I mean, there's always some type of an opportunity that you can then take and that become a lesson learned or an input into your next project. So one thing that I like to focus on is, and you guys will hear me say this at least 100 times this next 4 days, is clinically and operationally driven and technology enabled. I'm just going to let that sink in for a minute. And really what we're talking about with this phrase is that holistic approach to implementing changes or improvements that really emphasize the balance between clinical expertise, operational efficiency, and advanced technology. It's really that intersection. So hence the child of a computer programmer and a nurse, a career was born. This is what we do. And we try to bring those groups together. So when we talk about clinically driven, it means the initiative or the change needs to be led by clinical needs, clinical insights. We want to make sure that it aligns with best practices. And I think Alicia and Monique both spoke to this. We like to be involved in the conversation. We want to know that we're heard. It's much easier to get on board and support an initiative when it's done with you instead of to you. So that stakeholder engagement is really key. Operationally driven. Again, we're going to focus on, is it practical? Logistically, can we implement this? And it's really those processes, those administrative processes that support the clinical activities. And then lastly, we have technology enabled. And that means we're leveraging the technology to support and enhance the clinical and operational process. So all three perspectives, very, very valuable. All three perspectives should be engaged early on. And that's really that recipe for success. And when you combine this in the right atmosphere, the right culture, and everyone buys into it, you really are able to help create clinically relevant implementations that are beneficial to patient care, because at the end of the day, that's what it's all about. It's operationally feasible. It's sustainable. It's not some pie in the sky concept that you can't implement. So it needs to be feasible, practical. And then again, that it's enhanced by technology, because you want to take every opportunity to maximize effectiveness and efficiency. So it's really about bringing all three of those components together. So that brings us to Clinical Elevate. And what is Clinical Elevate and why are we here? You know, again, Sandy kind of mentioned it earlier. You know, we have a long-standing history. We've been in the business 25 plus years. And we have helped customers implement solutions for obviously 25 plus years. And we've done a good job with that. And we've also worked with customers to optimize their solutions. You know, but we want to go beyond just a set it and forget it. Process improvement, it's continuous. It's evolution. And you have to go back and revisit and make sure that you're still aligned and getting the expectations that you want. And so that really brought us to Clinical Elevate. And I'll give Ashley kudos for coming up with the term. She is one of our solution specialists. And when we heard that phrase, it was like, yep, that's it. That's exactly it. We want to be more clinically focused as an organization, and we want to really bolster that clinician stakeholder engagement throughout the process. We've invested in our clinical teams. We've expanded our clinical team. And this allows us to be that conduit between what our customers are hearing, what they're experiencing, and then how do we translate into improving our implementation or project delivery? How do we enhance that to be, we maintain business relationships after we implement? You know, we want to be that trusted business partner across the continuum. And so that's really what kind of led us to formalize this structure, this program. We wanted it to be flexible, modular, and again, at the end of the day, we want to be able to better serve our customers through implementation and beyond. So you'll see our objectives up here. I'm not really going to read those through you, but the first one, enhance all phases of delivery to be more clinically focused. And then the last one I think is super important, where we're talking about the value prop. We want to drive innovation, and that is through a rich understanding of what our customers' needs are. So, two very key things. And then I had to make the fun little graphic in the back because I kind of like a Venn diagram too. It's not just Kamala. So everybody likes those. So this is our Clinical Elevate team. Again, we have two team members here. Ashley and Erica's here. You also see their little pictures on the side. I'm just really proud of this group, so I wanted to showcase them. But our team is comprised of advanced practice nurse informaticists. We have a very well-rounded team. I don't want to make any of us feel old, but we've got over a century experience of bedside experience. And then add on 25 plus years of industry experience in alarm management solutions, unified communication solutions. So our team really brings a lot to the table. And you'll see the quote here out of Journal of Nursing Excellence, again, kind of promoting the value of having nursing involved in this process and really the understanding and the lens that we can bring to the table. And when you couple that with the brilliant minds that we have with our solutions innovation team, our product development team, we're poised to really do some neat things. And again, it goes back to the investment that Connexall is making in the clinical team here. So it's a lot of information. What is it? How do we do it? Just simply stated, observations, interviews. We're going to look at data if you're a current customer. We're going to follow up with you after we implement. Again, that's something actually kind of new for us to have that as a formal process. And then the one here with the binoculars, it's on site. We must engage on site. And I think that goes to Monique's standpoint that she spoke quite detailed about. You need to have that rich understanding. And you're not really going to get that unless you spend time with the people doing the work. You spend time with the group, you get an opportunity to see what technology they have in play. what's really going on their unit. Is there something really wonky about the unit that's a barrier to moving forward with the implementation? And I'll give you an example of one of the first process improvement things I did. And sorry, this has nothing to do with Connexall, but it was just logical, common sense stuff. We're on this process improvement team to figure out why we're spending so much money in linen. Now, before I was on this team, I had no idea that we were charged per the pound for soiled linen. Okay, so, and if you're a clinician, you know that if you take linen into the room, whether you use it or not, it is now dirty. So we had a couple of units that just had really crazy linen cost, and we couldn't figure out why until we went and walked the unit, and it's a long hallway, 35 beds, one linen cart, all the way at the end of the hall. So to save steps, because it was inefficient, you saw every nurse grabbing a big bag of linen and dragging it down and distributing it to their patients' rooms. Can't blame them. It's time, it's efficiency. But again, it was that compounded impact of, okay, this is clunky. Why is it clunky? It's a very simple solution. Let's put a linen cart at each end of the hallway. Maybe we'll throw a third one in the middle. So again, it's that on-site discovery and really partnering with our customers to understand what they're experiencing so we can help craft solutions to solve it. So when we're talking about Clinical Elevate, again, it's a process and a methodology that we have hardwired into all of our implementations. We launched this earlier in the year, kind of on a rolling platform. It's now hardwired into our implementations. And you'll see all the key components that this entails. At the top, you will see clinical stakeholder engagement. We want that relationship early. We want it to be meaningful, and we want it to extend beyond go live. You'll see our workflow broken up into a couple of different sections, direct observation being the top and really one of the most important, structured interviews, and then workflow design sessions. So again, how are we going to tackle and devise a workflow that is feasible and can actually be implemented? With this, because you also have to think, how does the technology play into clinical practice? What is that overlap? What is the touch point? We need to look at relevant policy and procedures. If we're implementing a fall solution, need to look at your fall policies, need to look at your fall data. We want to do observations. What technologies outside of a bed alarm are you using? So again, it's that comprehensive review of policy procedure. Education is key. How do you prepare your direct clinicians to be successful? Do we educate them once a year? Only when something bad happens? Never? I mean, all those things become really relevant. There's tons of research that shows, there's a direct correlation between outcomes and education. Clinical governance structures. Alicia spoke to this quite well, and it was like that needs to be the model for a governance structure. And it was really refreshing to hear. It sounded like it was extremely efficient, clear scope and guidelines of what they were responsible for, and they made decisions timely and at a system level. So again, we want to understand your decision-making process. So again, we can work with you, make sure that we have the right people making decisions that are going to impact clinical workflow across the continuum. Obviously, end-user training, go-live support, those are pretty straightforward. KPIs and surveys, we want to be able to measure clinical success with you. So we have formalized a process during implementation to make sure that we have those measures that we can go back and assess effectiveness. Some of those are actually hard data using some of our Connexall reports. Others, it's more subjective, but it involves clinician perception as well around fall prevention and around alarm management, alarm fatigue, and safety. And then you'll see on the bottom again of this list, it's that 2 check-ins with the team member that implemented the solution alongside you during that stabilization period. So it's not just the go live, wish you well, it's we're here to make sure that this works, and we're invested in it as much as you are. So that's what we do during implementation. And you'll see I changed the graphic, but if you read it, it's really the same thing. I mean, just might as well be transparent about it. We've been doing this work for years. We just needed to formalize a program around it. And when you talk about process improvement being a continuum, you need a reliable process that you can obviously evaluate when something changes in your environment. Maybe you're implementing a new staffing model. Maybe you've added new tech to the landscape that may have an impact on workflow. Maybe you're just really proactive and you want to pulse check that you're on target and you're using the latest best practices. You're using the system to its effectiveness. And this gives us that mechanism to check in proactively and to do that health check. And again, we're using the same foundational methodology that we have baked into our implementation. So, you know, as we spoke about in the first couple of slides, there's tons of information coming at you personally. There's tons of information coming at you professionally. And it doesn't look like it's going to throttle back anytime soon. So we know that this is a lot of information coming at you. As our customers, you're experiencing this. And we also know alarm fatigue is a very real problem. And so we want to partner with you. We know you're experiencing it. We realize that a more formal program and position allows us to better help you. And that's really why we built this, honestly. I'll give you a little bit of a teaser in closing, and then Sandy, I'll hand it back over to you. Our first breakout session of the day, Ashley is going to be presenting a use case that really illustrates Clinical Elevate, the value of it, and really kind of going, I've given you the overview and the methodology. She's going to show you the really cool stuff of the fact it worked. So, Sandy, anything?
No, I think the only thing I would add, thanks Jen, is you know, personal experience sometimes is really the best. I shared my story and background, you know, wishing there was a formal program that I could help work with the clinical leadership on this issue. Jan, you know, has experienced her own as informatics leader, whether it be, you know, EMR alerts and such. There, you know, the information's coming from everywhere, and so, you know, this program is really out there to help you work internally, make time, and work with us so that we can help improve clinician satisfaction, help improve the burnout issues that are really prevalent. And this is only a piece of that pie, obviously. It doesn't solve for everything, but we owe it to the clinicians who work hard every day. So with that, we'll open it up for questions. Not all at once with the paddles. I'm just joking. David took it for the team.
Hi, David Shivey, Stanford Healthcare. So when we deployed Connexall, one of the guiding principles was 75% of our alarms we wanted to not get dispatched. And we spent a lot of time selecting, I think at that point, 9 Philips alarms. And we spent a lot of time on how long we delay before we dispatch. And so we did that through spreadsheets and a lot of effort there and met our goal. And then we came back 3 years later and we had Connexall Business Intelligence, which allowed us to do that work through viewing a graph that showed us if we were at 25 seconds, then 30% of the alarms wouldn't get dispatched. But if you move that to 45, now all of a sudden, 60 or 70% wouldn't be dispatched. As far as I know, it doesn't seem like a whole lot of customers I've talked to have Connexall Business Intelligence, and it seems like it would be a great thing to bundle with your offering here. I just would love to hear thoughts on that and how you've used that in any of your deployments with customers around Clinical Elevate.
You want to start?
Sure. Totally spot on. We want to leverage the data we have available to drive insights and surface opportunities. We do leverage those business intelligence reports, and we actually are continuing to develop that toolkit. The one you described with predictive indicators, I mean, it's really nice. It allows you to really forecast what the impact would be. And then we can get away from the dirty pilot word and things like that, because you can really see the impact before you even make the change. We do have this, and I'll leave it a little bit of a teaser for the strategic roadmap discussion, because you will see analytics being part of that.
Yeah, the only thing I would add to Jan's feedback on that is that it'll be a feedback loop, right? To be able to go out, continually work with different clients, and then come back and inform how the business insights has helped the cause, right, if you will. But also, if there's gaps depending on the situation, type of alarm fatigue and the circumstances, to help improve the analytics tools as well.
Hey, how you doing? I'm Mike Bowering with Gaylord Specialty Healthcare. I'm just curious who your primary, typical stakeholders are. Are they generally just clinical people, or do you involve technical people in these conversations as well?
It's definitely combined. Our clinical and our technical team at Connexall works very closely together, and that's the model that we try to emulate with our customers. You need to have technical stakeholders at the table, and you also need clinical stakeholders at the table.
Thank you.
Mm-hmm.
Lori McCauley, Arkansas Children's. So coming from someone that's been in UC, probably I attained that title probably back in 2012, 2013, and I am not a clinician by trade, so let's be very clear about that. But I have really strong partnerships and a really strong trust with my clinical partners. And whenever you talk about coming in, I want to make sure that you see the whole team, right? Because from a business, and David spoke really well about analytics, where the value is in that, what you don't send. But what we're missing is how often we're churning technology in our systems that you don't see, or what the barrier is, or why we don't do it that way, and what is a best practice. Gotta love pediatrics, it's always different, or we think we are anyway. So this gives me a little bit of pause, because someone who's been live since 2012, I need to know, I have a concern that you don't know my workflows today. And then I feel the word dollars and cost to this, and so from that perspective, how do you get in my budget cycle for me to say that that has value, to get it in the operational budget and move it forward?
I can certainly start on this. So I think multi-pronged question. One of the things that we won't assume, although no one will probably fully declare, I don't have a notification or alarm management problem at all, right? I mean, that's the reality. But having said that, it's really important, to your point, to work with the hospital system to understand what the pain points are. So, having the conversation with the team, Lori, obviously, to be able to say, hey, it sounds like there's an issue, or you raising the issue, however this comes to surface, is really key, because then we can dive into those specific things. If you've changed like you said, since 2012, you've changed your medical devices, for example, you've changed other systems. We don't want to take that for granted. But we also think around, how do we need to frame this? What's the urgency? So you might say, this is a problem that's percolating, and from a budget cycle perspective, I have some time, versus this is a drop everything right now, urgent matter. And so I think ultimately we would work with each health system or customer, working through that process to say what's relevant as far as the issues or challenges, what's the speed you need to support you in terms of overcoming those challenges. And then, Jan and the team internally would, assign the right people for the task, because it's a diverse team with different skill sets, and many of the same, but also different in a variety of ways, depending on some of those factors. So it's definitely not one size fits all. I think Jan described it being modular, right, in terms of, If you have a big implementation coming up, it's embedded in the program. But if you've been a customer of ours since 2012, it's also a standalone program that meets the needs, because it's not one size fits all. Anything to add, Jan?
No, I think that's spot on, you know, and again, when we're looking at workflow, the reason we kind of expand that to what are your policies and procedures and your education is we realize that there are other factors or constraints that really help architect what that workflow is. You know, it can look great on paper, but is it really sustainable? So
Jan, I think where we miss the mark is when we bring in a new technology, we're not adding in the dollars for you to help us.
gotcha.
You're not part of that. You're not part of our BDLRs and comp project. You're not part of our epic moving to alerts and alarms because we have history. You're not baked in that operational project cost.
Thank you for that. I appreciate that feedback.
Yeah, good feedback. Thank you, Laura.
So I'm Ashley Hunsucker with Connexall Clinical Solution Specialist. So just to give a comment more than a question for the audience, what we were noticing on the clinical side of the house was a lot of our customers were coming to us with alarm fatigue, right? And if 2020 taught the nurses anything, was fatigue. So the idea started brewing, and we birthed Clinical Elevate to give our customers an opportunity for us to reevaluate your service lines, your changing in your resources, your matrix that your nurses are now having to work on versus prior to COVID. You may have been a 4-to-1 unit, and COVID showed the leadership, hey, your nurses can actually do a 6-to-1, and those ratios never changed. So we're doing more and expected to do more on less. So the clinical team at Connexall, we came together and said, we need to support our customers, and how can we do that? And so Clinical Elevate was, envisioned and put forth, and the idea behind it is to support your end users, which are your clinicians. So however we can support that, either with a new technology or your old, to revisit that is what we're really trying to be impactful for with Clinical Elevate. So it may not work for everybody, but you may be hearing some rumbles and grumbles from your staff, or the phone goes into the drawer and they never pick it up or never log out. And so what we're trying to do is trying to help minimize that. And so to get your clinicians more bought into understanding why they're getting alarms, why that's coming to them, how can we make it better, right? So you can find me if you have any more questions.
Thank you.
Hi, Kareem Jessa, CMIO at Sick Kids in Toronto. So really interesting discussion about what Clinical Elevate can do. I see the role by my colleague here from Arkansas really around the role of clinical informatics. And Jan, you've hit the nail right on the head. So how much of that work would be done by our clinical informatics team, and how much are we outsourcing to Connexall, and what are the touch points? And that's just part of a partnership, because some of these projects that we're going to be doing may not have any relevance to Connexall per se, or we might not think it does.
Right.
But you as the solution architects might say, hey, did you know you don't need to have Vocera. You can do everything just through this, or you can leverage your existing infrastructure. And that's knowing what we have implemented. So I really look for a long-term partnership with Connexall. We might engage you early and often, and you might not want to take our phone calls because, here's another false alarm, or Kareem is calling again, It's like, so help me understand the overlap between our local informatics team and your informatics team.
Sure. And that's a great question, and I'll always take your phone call, even if I just forward it to Sandy's personal email. Yeah. But seriously, I mean, that's what sparks innovation. So we want to hear the challenges, we want to know the opportunities where we can help. Your question really is, there's not a one-size-fits-all. And a lot of that will depend on, what is the maturity and the scope of your informatics team. We certainly can partner and work closely with your informatics team. What our informaticists bring to the table is that richer understanding of Connexall. And that's kind of that one gap. So again, is it something we can work in parallel with? Absolutely. But if you're designing workflow, our best practice is that it does include one of our solution specialists, but obviously can work in concert with your nurse informaticists as well.
And the only thing I'd add to what Jan said too is it might come down to the primary system. It might come down to the medical device, but because that information is flowing through Connexall, that's where maybe perhaps a change needs to be looked at based on clinician feedback. So there are, tentacles that go out and beyond Connexall as well, but primarily obviously with Connexall in mind, and looking at, alarm fatigue specifically, right? All these, as we described earlier in the presentation, just this information overload, and what do we really need to send to those clinicians, and what don't we need to send, for example?